of these few slides to explain why it is important and what are the initial symptoms and signs. You should know how to recognize these problems and how do we investigate an initial management. Usually, as a doctor, we usually refer to the specialist, right? But you should know basic management system. Sometimes when you look at the slides, it could be look like a revision class for final MBBS structured essay question. I don't know who are the people going to sit for the repeat, but it looks like that, right? So we'll discuss something about the megacolon and the colonic emergency, small bowel obstruction, then peritonitis, primary, secondary, and tertiary peritonitis, biliary problem including gallbladder and biliary problems, and finally we come to the esophageal perforation. So these are the some of the most commonly happen emergencies in the GI tract. So the first case study, there are two cases. One is 76-year-old lady who presented with type 2 diabetic and congestive heart failure, admitted with diarrhea, distended and tender abdomen. Blood pressure is 90/60, WBC count 19,000. Recently treated with broad spectrum antibiotic and hospital acquired pneumonia. That is the first one. And second, a 23-year-old man with a known history of ulcerative colitis presented in the emergency department with 10 to 15 times bowel opening per day with the last 48 hours with a distended abdomen, mild tender. Blood pressure is 110/60, WBC count of 70,000. So, first you should recognize who is more sick in these two scenarios. Any yes, who is more sick? First scenario, 76-year-old lady more sick, or 23-year-old man with known history of ulcerative colitis more sick? First one. What's the answer? Who are the people thinking first? A 76-year-old lady is more sicker than 1, 2, 3, 4, 5, 6, 7, 8. So others thinking the 23-year-old man is a sick. What's the answer? So, no one. And the thing is, why one of you can tell me why you think the first one is more sicker? What parameters make you to think like that? Huh? Yes, what parameters? Huh?
Marginal blood pressure.
Blood pressure, okay, marginal blood pressure.
So age and the comorbidity.
Okay. The marginal, you think the marginal blood pressure, you think a patient with congestive cardiac failure, this is the marginal blood pressure. It may be a hypertension problem. It could be hypertension problem. No. The thing is, this is not that's what they are telling from this case scenario. Don't assume like that. We don't have any answers in the slide, but the take home message from this slide is any of these can be a signal. And the blood pressure between 90/60 in one lady, old lady, and 110/60, you can't take any decision. We don't know what is a normal blood pressure of them. Sometimes the congestive cardiac failure, that is a normal blood pressure. That is a normal blood pressure. And 23-year-old man, they withstand blood pressure until the late stage. Right? So we don't have any idea. So that is the assumption you should take. So always vigilant and do other investigation and routine assessment should be done until the changes start to happen. Right? What do you think? What are the possible differential diagnoses in the first scenario? treated with broad spectrum antibiotic presented with distended tent abdomen. But they did not mention anything about gardening rigidity. There is no features of petronism. But WBC count is 19,000. Definitely we need more information, but what are things should come to your mind? Pseudomembranous colitis. Usually we think like that, no, distended abdomen with past history or recent history of antibiotics. Possible thing is pseudomembranous colitis. Second scenario, patient with ulcerative colitis now looks like a flare-up of disease with distended abdomen. What could be the bad situation they can come across? Ulcerative colitis, toxic megacolon. We don't know, but it could be a toxic megacolon. That's how you should think. Common is common. Common is common. Right? So, what is toxic megacolon? You should know that severe total or segmental colonic distension. It could usually happen in the transverse colon, but it can be a total complete colon or maybe a segmental. With systemic toxicity, that's a very important, and sepsis. Systemic toxicity and sepsis. Usually in the large bowel, we see the functional obstruction or functional distension, Ogilvie's disease, which is not sepsis, no tenderness, only the distended abdomen. Right? Here it is not like that. It is a toxic megacolon because it's megacolon plus toxicity. Usually it caused by the Clostridium difficile infection. Usual association is inflammatory bowel disease, but can be due to any other causes, volvulus, infections, ischemia, anything can cause, but commonly in patients with ulcerative colitis, get this infection. So always you should think about toxic megacolon in inflammatory bowel disease, but other condition also you should think about. So it is not clear anyway. Usually in the diagnosis, first thing we do basic lab test. Clinical examination, unless there is a perforation, you won't see any signs of perforation. That's important thing. Don't assume that there's no perforation, so there's no chance of toxic megacolon. No. Initial stage, most of the time, until the last stage, they will have the distended abdomen, no perforation. Lactic acidosis will be there because when it is distant at one stage, what will happen? Mucosal necrosis will start because inflammation, edema, which causes mucosal blood supply, compromisation of the blood supply to the mucosa. So lactic acid acidosis will be the early warning sign. That's why we see the lactate level assessment we do in the patients where it is available. Usually the ICU patients or patients in under monitoring, we do the lactic acidosis. And I don't know whether anybody remember, that is one final year MCQ, lactic acidosis used as a early warning sign for the to assess the bowel ischemia or adhesive intestinal obstruction. That is one warning sign where you have turned your decision to laparotomy or laparoscopy to surgical intervention. So that is one important sign. So again, many slides, this kind of slide will come. What is the management? You will come across same management. There's no difference. Like our final MBBS structured essay questions, management is same. All the essays, the management part, you can again, as medical students, you can write the same thing again and again, right? Usually, GI tract, patients with emergencies, don't give anything, nil by mouth. And if there's no damage in the upper tract or stomach, you can easily insert the NG-tube. For example, toxic megacolon, easily you can insert the NG-tube. And aggressive fluid resuscitation, that's the important part of all these GI tract problem. Aggressive resuscitation should be given, usually Hardman solution. And if necessary, we have to give potassium as well. Sodium usually replaced by the fluid, but potassium you should give. In toxic megacolon, rectal examination important. You should exclude by plain abdominal X-ray and rectal examination. There is no distal obstruction. You resuscitate the patient. Patient is having some rectal obstruction or malignant obstruction. They also can develop. So then what will happen? Patient will deteriorate by perforation. So then you have to consult with the surgical consultation, and the operative assessment should be done whether they need an operation or whether it is settled. Important thing, not for toxic megacolon, any suspicious bowel obstruction, whether it's a small bowel obstruction, large bowel obstruction. Both you should not give, laxative should not be given, anti-motility drugs should not be given, motility drugs should not be given. For example, domperidone should not be given. Because if the patient is vomiting, if you give domperidone, what will happen? Chance of perforation. Laxative, what will happen? Increase the accumulation of fluid in the small bowel. Again, in early perforation. So you should think twice while starting this drug, because patient came with bowel not open for some days. You can't just start the laxative. Right? So before starting the laxative or motility drugs, anti-motility or motility drugs, you should make sure X-ray and there's no signs of bowel obstruction or bowel dilatation. So toxic megacolon, you should be very careful because patient is toxic. You should not make worse, or your management should not make worse the patient's condition. Specific management, Clostridium difficile is a common organism, so you start the vancomycin. Usually the drug of choice in Sri Lanka is vancomycin. Rectal vancomycin also available if not you have no other alternative. Oral. And in addition, you can start the IV metronidazole in the fulminant conditions or maybe suspect perforation. So, patient's condition not improving, we have to resect the bowel, complete total colectomy, or maybe a segment should be resected. Think about the anastomosis. Usually we don't do the anastomosis, we make it as a colostomy, but that is a basic thing. In inflammatory bowel disease, if it is due to inflammatory bowel disease and causing this toxic megacolon, then you treat with the hydrocortisone, steroids. IV steroids should be started, hydrocortisone should start. And if not improved, patient is not improved within 24 to 48 hours, we think about surgical intervention. Or if there is a mechanical obstruction, then there is no other alternative. We may need at least basic thing. We do what? Colostomy. Depending on the site, we do the colostomy. That's a minimum thing, and it is a safe for the patient. So this is basically we do for the toxic megacolon or any bad colon. So in case study 2, 75-year-old woman with history of hypertension and type 2 diabetes. 3-day history of abdominal pain associated with nausea and vomiting. Again, blood pressure is 90/68, heart rate 110 beats per minute, respiratory rate 24, temperature 38, oxygen saturation 98 with 2 liters of oxygen from 9 to 2 now. She has dyspnea only with exertion, otherwise she has no dyspnea. First thing, what are the possible diagnosis or differential diagnosis this patient may have? Again, the old lady, hypertension and diabetes, 3 days history of abdominal pain associated with nausea and vomiting. site of the pain. Whether it's a right hypochondrial pain, whether it's an epigastric pain, central abdominal pain, RAF pain, lower abdominal pain, we don't know. Examination wise, whether patient is having any features of pleurodism. Features of pleurodism different. Without pleurodism, just distension is different. Right? And whether the patient has had any past history of surgery, abdominal surgeries, which causes any obstruction or any bowel problem. So, these are basic things when a patient presents with pain. Plus nausea and vomiting, you should think about one cause is pain can cause nausea, more nausea and minor vomiting. Intestinal obstruction causes significant vomiting and mild nausea. So you should know that. And usually, if it is proximal obstruction, small bowel obstruction, proximal obstruction, it could be a projectile vomiting. It could be a projectile vomiting. And sufficient splash will be positive. So these are some of the clinical findings you should search. Then depending on the finding, we can come to a conclusion or differential diagnosis, or we can plan our investigations. So whether it's in Western world or Eastern world, common cause for the small bowel obstruction in a virgin abdomen is a hernia. In a virgin abdomen is a hernia. Right? Most commonly, femoral and inguinal hernias are the common sites for the small bowel obstruction. But in a patient with past history of surgery, whatever the surgery, adhesive intestinal obstruction is a common source. There's no other words, anywhere in the world. All other differential diagnoses or causes are second to bottom of the list. Inflammatory bowel disease causes adhesions, intussusception, adults intussusception, volvulus can happen anywhere in the small bowel, gallstone ileus, trauma, foreign body, desires and desires. So, malignancy, very rarely malignancy, especially GIST, gastrointestinal stromal tumors, or sometimes submucosal lipomas. All these can cause small bowel obstructions. Again, it could be a partial or subacute intestinal obstruction, small bowel obstruction, but fluid can pass, but the content of the fluid or the content of the small bowel or the small particles will not pass. So they will pass air and other things. So initially, and they will have plates, gas in the large bowel, all these features will be there. So it is called subacute or partial bowel obstruction. Or complete bowel obstruction, completely nothing will pass, so quickly they will go into the worsen scenario. And other condition is a closed loop obstruction. Closed loop obstruction usually we can diagnose by X-ray, plain abdominal X-ray. But in addition, you can see the closed loop plus proximal to the obstruction line, even the normal bowel also will be dilated. Because there is obstruction, or it looks like that. Closed loop is a site of obstruction. But what will happen easily, quickly they will go into the perforation if we are not identified and manage the patient. What will happen easily, distant, easily mucosal necrosis and perforation will happen. So these are three types of small bowel obstruction can happen. And again the management same. Non-surgical, or we call it as a resuscitation of the small bowel obstruction. Fluid resuscitation, electrolyte resuscitation or correction, NG tube insertion, and nil by mouth. So usually virgin abdomen, most of the time patient need a surgical intervention. Adhesive intestinal obstruction, 50% of the chance they will settle, 50% of the time they will go into the surgery. But there are some criteria which is not the part of this slide, but usually after 72 hours, it is not settled, we should do the surgery. If there is a deterioration in the hemodynamic state, CT scan, penta-second CT scan will give a guide for your investigation, your management, diagnosis and management. So that is depend on the condition, distension, we plan laparotomy or laparoscopy. Severely distended small bowel, usually there is no space for laparoscopy. But there are places where we use laparoscopy, adhesive small band, congenital bands, or small adhesive intestinal obstruction, we can relieve by laparoscopy, right? So, important thing, depend on the surgery, the post-operative monitoring will depend, but please think when you are giving a resuscitation and when you are giving the post-op care, it is a goal-directed treatment. Blood pressure, pulse rate, urine output. Depend on these things, you can adjust your monitor, fluids, analgesia, antibiotics, all these things can be monitored. When the patient is worsening, sometimes there may be a leak from the anastomotic side, or there may be an infection, right? So post-operatively you should monitor all these things, including the feed, whatever the intra-abdominal surgeries. So third thing, we come to a case 3, a 58-year-old man with a history of diverticulitis present to the emergency department with diffuse abdominal pain, nausea, vomiting and fever. He has mild history of worsening nausea, anorexia and genital malaise and abdominal pain. It is not single day, it's a fight. So, physical examination, diffuse tender abdomen, predominantly in the LA region. Anybody tell me what is the most likely diagnosis here? What is the most likely diagnosis in your mind? What is the most likely diagnosis? Yes. What could be the most likely diagnosis here? Diverticulitis, they have given no patient known with diverticulitis. Diverticulitis, perforation also common. Usually diverticulitis can perforate, but that is not the specific condition here. More than that, what is that? Abscess also can happen. Worst condition of the diverticulitis? Worst scenario? Generalized peritonitis. But it is very rare. Usually it won't happen because it is in the sigmoid colon. But if diverticulitis and other things happening in the transverse colon, ascending colon, descending colon, sometimes the patient may develop perforation and generalized peritonitis. Usually start with localized pain. That's why they give the history like 5 days history of nausea and things like that. It was a localized perforation, maybe abscess formation. Patient immune system is not working well, spreading into the abdominal cavity. So that's how usually it happens. These are the old people, they are not young, more than 60, 65 years. Usually immunocompromised, diabetes and other problems. So worsening of the diverticulitis and abscess, that is a common scenario. So usually these people present with peritonitis after week, 1 week, 2 weeks. It won't happen immediately. It won't happen immediately. First, 1 day history of acute abdomen will not be a perforated and generalized peritonitis of diverticular disease. So you should think about that. But according to the scenario, it is a diverticulitis now complicated with generalized peritonitis. So in this slide, what are the type of peritonitis? Primary, secondary and tertiary. Primary, you know, that is happening spontaneously, it is happening without any perforation, without any source of infection. Usually translocation of the bacteria or hematological spread, it can happen. Just peritonitis, primary peritonitis. Again, the immunocompromised people, pregnant mothers, these are common, or the postpartum mothers are common victim for this disease. Secondary, we know after appendicitis, cholecystitis, or bowel perforation, anastomosis, whatever. Surgery is a recurrent and due to after the treatment they develop again and again. Right? So you should know to diagnose what are the investigations you should do and how do you treat these things. What investigation will help you to diagnose peritonitis? One thing, clinical examination. You can't substitute for this clinical examination signs of peritonism that will be all over the abdomen. Then until prove otherwise it's a peritonism. Plus, what are the lab tests will help you? What are the lab tests will help you? In generalized peritonitis. Definitely WBC count and inflammatory markers will be very high. Usually 18,000, more than 18,000. Right at 300, 250, 300. Serious. More than that? What else will help? More than that, what else? Usually in the laboratory studies, metabolic panel will help. Metabolic panel means metabolic study you can do. That is one thing. Second thing, albumin level or the ascites or the fluid in the peritoneal cavity or peritoneal area, you compare with the serum protein. If it is more than 1.1, it could be due to more. That means it is due to portal hypertension or other liver causes rather than purely due to primary peritonitis or the peritonitis. But we usually don't use this investigation, but can help. But otherwise, you usually we do the ultrasound scan, CT scan can identify whether it's a pure and simple serous fluid or it's an abscess thick fluid. If there are some particles, they can identify. Plain abdominal X-ray, usually after perforation of the viscous. Usually there won't be any bowel gas. That is one. Double gas shadow. The whole either side of the bowel wall, you can see the gas. Inside the lumen, outside the lumen. So these are the features. And gas forming organism, primary peritonitis, gas forming organism for gas under the abdomen. That is other thing. Without organism. So these are some investigation, but give a flow, you have to assessment. Right? So again the treatment, resuscitation, start with the resuscitation. We know and we should start antibiotics, as we know we should start antibiotics. Source control is an important thing. Depend on the diagnosis, source control. For example, if it is due to diverticular disease, diverticulitis, abscess and perforation, most of the time patient will end up with Hartmann's procedure. We resect the part of the bowel which contains the diverticulum and remove. We don't do any anastomosis, minimal intervention, damage control surgery. So we only do the Hartmann's procedure, remove the part of the bowel and so. Right? And antibiotic again, both generations of Lascaux usually we use in a peritonitis because it's multi-organs and the patients are immunocompromised. That's an important thing. They usually don't happen in a normal person. Gabapenum is usually we use here. So in fourth case study, this is again a postpartum 24-year-old woman in ICU. Peripartum cardiomyopathy. She is mechanically ventilated on vasopressors and inotropes. She is jaundice first. She has been receiving total parenteral nutrition. Now tell me what could be the reason 24-year-old lady in ventilator jaundice. What could be the reason for this? Any idea? What is the condition? It could be anything, but there's no answer in the slide. These are just assumptions. What could be the condition? Yes? What do you think? A-calculus cholecystitis. So what is the relationship between A-calculus cholecystitis and jaundice? Is it jaundice? Why why this patient developed jaundice? Acalculous cholecystitis. So what is the reason for acalculous cholecystitis? Not only this patient, what is the basic, there are so many mechanisms they have explained, but what is the main thing, what is the main reason, basic pathological phenomena behind the acalculous cholecystitis? Why this cholecystitis happen? Calculous cholecystitis? Stasis. UTI, stasis. Everything is stasis now. When there is a stasis of urine, stasis of bile, infection will happen. So in what category acalculous patient it happened? It is happening. What are the reasons for this cholecystitis? Acalculous cholecystitis in ICU patient, ventilator dependent patients. What is the reason? There is a paralysis of that organ. That is the main reason. One reason is the paralysis of the organ, gallbladder paralysis, or small bowel paralysis, large bowel, anything can happen. Electrolytes imbalance, nutritional imbalance, neurological problem, anything can cause the paralysis of the organ. That causes stasis because gallbladder will not contract. Similarly, CBD also will not push the bile into the small bowel. So this acalculous cholecystitis patients, usually you can see in ICU patient, why these patients will have paralytic ileus, acalculous cholecystitis, jaundice, all these are related things, common problem. Most of the time, one reason is a paralysis, second reason a very concentrated bile. So very concentrated bile will not flow easily. That also can cause obstruction of the cystic duct, or it may stay in the common bile. So that could be one problem. But more than that, what are the emergencies we should consider? Cholecystitis, maybe calculus and acalculous cholecystitis, oligopolythiasis, which is common bile duct stone, possible, pancreatitis, cholangitis, and trauma in the biliary tract, external and iatrogenic, anything can happen during the surgery, during ERCP, or any adjacent surgeries we can damage the biliary disease. So all these are biliary emergencies. Bile in the peritoneal cavity is an emergency. If it is happened and not diagnosed, high chance patient will die. High chance patient will die. Right? So what is the next step in the management? Usually what is the next step if a patient, 24-year-old lady, come to the emergency department with jaundice and pain? What is the next step in the management? Two things we do. One, always we do the ultrasound scan, because biliary system ultrasound scan is a basic radiological investigation, and liver function test. In addition, if you want, you can do the WBC count and CTRB to see whether the patient is on sepsis. These are the basic investigations we usually do, right? The management wise, again I am telling fluid resuscitation. Broad spectrum antibiotic, usually third generation cephalosporin, and sepsis evaluation usually. Right? So alkaline phosphatase, gamma GT levels will give whether the patient is having any CBD obstruction or CBD calculus or CBD infection. Depend on that, we think about the management. Right? Usually, basic investigation is more than enough to diagnose the emergencies in the biliary system. Ultrasound scan is more than enough to diagnose any biliary emergencies. More than enough. So there's no high-five things. Then you can think about your treatment plan. Management, as we already started, definitive management, source control. That's the only thing we have to do. Or if there's any obstruction, sometimes we need a ERCP and stenting. Right? ERCP and stenting. Whether it's a calculus, acalculus, it doesn't matter. If a patient presents with Cholecystitis management is same. For cholecystectomy, if patient is fit, but ventilator patient we don't do. So internal cholecystectomy should be done because there are some problems going on with the system, right? Or if the patient is worsened, hemodynamically worsened, we ask for the help from the radiologist to insert the drain to decompress the system. That's it. So again, as a whole, fluid resuscitation, source control and definitive treatment, these are three parts in the biliary system. Right, this is fifth case study. 43-year-old man with past medical history of alcohol abuse. Presented to the emergency department with chest pain, fever, chills and tachycardia. WBC count 17,000, nausea and retching 15 times overnight. What could be the problem? Alcohol abuse. Emergency department, chest pain, fever, chills and tachycardia. But had a history of nausea and retching 15 times overnight. What could be the problem? Which part of the body is now in the problem? With this history can you identify? Any idea? Definitely we need some more information whether what is the saturation of this patient. Whether the patient is tachypneic. Definitely these patients are tachypneic and reduced blood efficiency. So what could be the complication can happen in a patient with vomiting, retching many times. Chances of esophageal disease, but esophageal perforation. High chance for esophageal perforation. So usually esophageal perforation patient within 6 to 8 hours they will go into the deterioration. It's very quick because it causes mediastinitis. One of the other worst condition in the body, mediastinitis, quickly it will go into worse condition and very difficult to bring back the patient to normal situation. So unless we diagnose early, it is very difficult. Again, how do you manage the patients? Resuscitation is an important part. Antibiotic is very important because mediastinitis will be a worse scenario. Sometimes antifungal treatment, the patient depends on the patient's immunosuppression, source identification or the site of the perforation, and if necessary we do the CT scan, but usually initially we can do the erect chest X-ray where we can see the perforation and the gas in the mediastinum. Clinically, sometimes we can see the emphysema, surgical emphysema, the chest, upper chest region or neck region. These are the common clinical findings. And it could be due to recurrent vomiting or could be foreign body, could be post-surgical or intervention. Or sometimes malignancy can cause spontaneous perforation. So, patient with dysphagia, patient with esophageal cancer, suddenly they can develop. Or after the upper GI endoscopy, very rare, but it can develop. Especially the patient with malignancy and upper GI endoscopy, chance of perforation is high. Vomiting chances of high. Recurrent vomiting, many times after alcohol intake they will vomit. That causes Bohemian disease, perforation, spontaneous perforation of the lower part of the esophagus. Right, so sometimes we need contrast study. Yeah, we can see the contrast leak. Easily we can diagnose. If there's a contrast leak, we can do the CT scan and contrast it. So we know the causes. Very rarely it can be due to upper GI endoscopy, but nowadays it's a flexible endoscopy. It is rarely causes perforation. But sometimes what will happen, we do the procedures like dilatation of the strictures, biopsy from the malignancy, which causes easily we can perforate into the mediastinum. Again, the management, as I told you, nothing by mouth, nil by mouth. Antiemetics we can give easily, which prevent the gastric juice coming into the esophagus. Then we can start the source control. Most of the time it is surgical, but endoscopically you can put a stent, which will prevent the leaking of the fluid from the esophagus to mediastinum, further leaking. Then we plan for the thoracoscopy or thoracotomy and washout of the mediastinum. Usually they need a mediastinal washout with ICQ infection. Any questions? I know you won't ask any questions, right? Any questions? Right, so the take-home message of these slides, one point you should remember, lactic acidosis. When a patient is lactic acidosis, there's a chance of bowel ischemia, bowel gangrene, bowel perforation, worsening of the bowel obstruction. Second thing, you should know the causes of small bowel obstruction, the virgin abdomen, and patient who has undergone surgery in the past, and the peritonitis. But other causes of it is not only due to bowel perforation; it can be primary. Sometimes we only manage with antibiotics without doing any laparoscopy, right? And you should identify the biliary emergencies in the early stage, because as I told you, biliary peritonitis is one of the worst peritonitis. Then esophageal perforation. Usually esophageal perforation is a highly specialized area. Person should manage, and it's quickly patient will go into the bad condition, bad to worse condition, right? So these are things we have discussed, starting from the toxic megacolon, small bowel obstruction, peritonitis, biliary sepsis, and esophageal perforation. Any questions? Or as usual, FCCS course.